So many people suffer from heart failure or even heart attack after long-term dialysis. Of course, this is not due to the dialysis. It's just due to the fact that dialysis is imperfect. It cannot actually cover the function of the kidney completely. So of course, it's unfortunate that the statistics show that the 5 years survival of dialysis patient is actually less than 50%.
Specialist Centre isn't your typical hospital. It's Malaysia's premier quaternary hospital where rare, complex and next-level care comes to life. This is Quaternary Care, where our team of trusted super consultants are here to take on your toughest health battles using advanced technology and research-backed treatments all under one roof. Now, back to Nadia Azmi for UMSC's QRATED podcast.
Welcome back to QRATED, brought to you by Specialist Centre or UMSC. In the first part, we talked about our kidneys and also organ donation, in particular kidney donation. And right now, we are going to delve deeper into the transplant process from diagnosis to dialysis, the role of the OR or operating theatre, and what it looks like after a new kidney starts working. All right, so we are still with Prof. Lim and also Prof. Shanga. We've had a very intimate or in-depth conversation about our kidneys and the need to protect it, and also about becoming a kidney donor. Right now, let's go more into the diagnosing part. So that's where you come in first, Prof. Lim. Diagnosing kidney failure. When kidney problems start to show up, how do you actually diagnose a patient?
Yes, I think probably just a very three simple point. The first point is kidney disease has no symptom.
Wow.
Right. So especially at the early stage. So it shouldn't be based on symptoms to make a diagnosis. That's why we focus a lot on screening for those high risk individuals.
Screening?
Screening means early detection. You do some tests to aim for early detection.
So patients actually have to be proactive in that sense.
Correct.
And come to the hospital to meet with someone like you and to check whether there's something wrong with their body.
It may not be a nephrologist.
Okay.
Right? It can be general practitioner. Okay. It can be primary care physician. And I would say in Malaysia, 70% of people probably will start off with the GPs or primary care physician. So the screening is actually very important because we cannot base on symptoms. Because when you talk about symptoms, it's very late stage of kidney disease. It might be too late to do anything.
I think maybe a general medical checkup every year is a form of screening, right?
Yes, that is actually because most of the time you do blood tests and urine tests, right? And
they'll show up there if there are problems with the kidney.
That is good enough. So that comes to my second point. If there are any signals of kidney disease from this simple medical checkup, which can be blood or protein in the urine or abnormal kidney function, where the kidney function not appropriate to your age, or you have high blood pressure at young age. So young age means less than 45. So if you have high blood pressure at young age, one of the things you have to check is your kidney function. So if you have signal, then of course you have to seek medical attention. So that is the second point. The third point is the reason why we want to emphasize that is because nowadays, compared to 10 years ago, we have many treatments option. So 10 years ago, people come to me, I only have one that I can do. That is one of the medication to treat the blood pressure, to control their protein leaking. But now we have 4, right? So there are many treatment options now. And the earlier people come forward, we will be able to treat them more effectively. We have more time to actually treat them, and there will be a chance to actually prevent kidney failure in their lifetime. And that's something that I always tell my patient. As a nephrologist, my task is not to manage a kidney failure, to prepare you for transplant. No, that is not my daily activities. My daily task is actually to get people at the early stage, get them treated properly so that they can prevent them going into kidney failure.
Because there are no symptoms, so it can be quite challenging to diagnose kidney failure. But let's say, it's at the later stage and symptoms do start appearing. What will be the symptoms?
The symptoms will come back to the function of the kidney. So that means we talk about excreting waste product, right? So when the waste product is accumulating, we call it toxin. So people will get lost appetite, they start vomiting, and some of them may become confused because the toxin might go up to the brain. right? So that is one of the symptoms. The other one is we are talking about urine production, right? So if the kidney not functioning, people might not be producing urine properly. So there will be water retention.
Yeah.
They find themselves having leg swelling, or the water might go into the lung. They might feel breathless. So this is another important symptoms.
So is it really too late by then when these symptoms start showing?
Unfortunately, yes.
What can they do still though? I mean, they'll still see you.
Of course, at that time, then our focus is slightly different.
Yeah.
Our focus is talk about symptom relief. We give them medication to relieve the symptom. Then we try to manage whatever complication that arise at that stage. And then, of course, we prepare them for dialysis or transplant.
Okay.
So you can see that the focus will be different at different stage. So if they come early, I'm not doing all this. I'm actually talking about how do we slow down the worsening of your kidney function, and then so that we can actually prevent kidney failure.
And they don't even have to go into dialysis.
Yes.
As a treatment option.
Yes.
Okay. Now we talked about earlier in part 1, because you are a nephrologist, Prof. Shankar is a urologist, and you both work as a team. Even though your expertise is different and what you do to the patients is different, how do your roles intersect after diagnosis?
Of course, a lot of time our work become closer when the patient have a much more advanced kidney disease, when it come to the stage where they need transplant. Then because we know that transplant is not a one-man show, you need a team, right? So that's why our task is to actually get our patient prepared properly, make sure they are suitable before we bring it to the team and discuss about the transplant surgery. So that is how we do our so-called multidisciplinary kind of discussion.
Okay. Prof. Shankar?
So, just going back on the diagnostic part, sometimes the kidney can fail because of obstruction, there might be a stone blocking the kidney, or there might be a tumor blocking, so there can be anatomical reasons for that as well. So that's where we urologists come in as well. We need to unblock the system, something like the plumbers actually,
So it's not really a failure on the kidney's part, meaning there's some other ancillary reasons around
that may be just transient failure. Yeah. Once we unblock the kidney usually gets back its function and functions normally again.
And that's conducted by you, that kind of operation or surgery that's conducted by you as well.
Surgery needed to unblock will be done by the urologist.
Okay. Yeah. Picking up what Prof. Lim mentioned, multidisciplinary. What is that? Okay, so UMSC is known for its multidisciplinary approach. So from your experience as specialists from different fields, and you have to work closely together, how does that method, that multidisciplinary approach, help improve patient outcomes?
Yeah, of course, all of us know that we might be good at our own area, but in order to actually get the best outcome of the patient, a lot of time we need the input of everyone. So the nephrologist need to give the input. The surgeon will actually need to come in and say whether the surgery is feasible. Then the anesthetic team might come in and say whether is it high risk of giving gas to the patients or not. Then the radiologist might actually point out and say, oh, this particular patient, the vessels might have problem. So to warn us that we have to be careful, and also all this. So you can see that different people give their input.
Yeah.
So we can reach a consensus and say, first of all, of course, whether this surgery is feasible to go ahead or not, and then what are the precautions we want to take. So that will be able to allow us to actually predict what are the complications that might happen. So with that kind of prediction, of course, we can actually guarantee a better outcome.
Yeah, so this kind of teamwork really helps, especially I think for complex cases like kidney failure or urological disorders. But Prof. Shankar, are there any instances where there are disagreements between the specialists and experts? So what happens then when you don't agree on things?
Of course, we have cancelled cases actually. We have refused to do a pair that has been presented to the surgeons. Even anesthetists have refused to do a pair because of potential anesthetic complications due to medical reasons. So we have also refused to accept a pair, maybe due to anatomical reasons like a short vessel. Because when we do an operation, the best outcome is obtained from a kidney that is retrieved with a single vessel, actually.
Okay.
Yeah. So when you have a single vessel, that is the best. You get the best outcome.
This would require more medical knowledge, but okay.
So if you have meaning if you have a single connection, if you it's like wiring,
So
if you look at the analogy
some
of
people might
wiring,
not have that.
correct. Some people may
Have
be
a few branches.
branches.
Yes.
They might have a few wires connecting wires that transmit blood. Actually, So those are that makes the operation a bit more complex. So the best outcome is with single connection. So if in the multidisciplinary meeting that we have regularly, if we find that the operation is going to be too complex, or it is going to be too dangerous for the donor to undergo this surgery, or the pair have got medical conditions that may affect the anesthesia for the success of the operation, then of course we have disagreed and have to look for another donor.
So it does happen.
Yeah,
it does happen.
It happens.
Let's go into more about the realities of dialysis. Perhaps maybe some of them who are watching, they have a parent or an uncle or an aunt who goes for dialysis on a weekly basis, right? Depending on how severe their condition or their situation is. So it's a life-saving intervention, but it can be, of course, tough on patients. If we have family members who are going through this, I think we will be witnessing this. Walk us through what dialysis actually does and how does it fit in the broader transplant process?
So if I actually tell you that dialysis is a kidney replacement therapy, so do you think that will explain what we are doing with dialysis?
So therapy, form of therapy.
Kidney replacement.
Kidney replacement.
So essentially, we are talking about that the kidneys are not functioning well. So we are using a treatment to replace the function of the kidney.
Yeah.
So in terms of clearing the toxin, in terms of clearing excess of water. So that basically is a essential function of the dialysis. Yeah. Sorry. So, and just now you mentioned dialysis is life-saving, and this is actually very important. If you look at other organ failure, heart failure, liver failure, they do not have any supporting system or treatment that can let the patient survive for a longer period of time. Only organ failure, among the organ failure, only kidney failure, you have dialysis an option that can sustain a patient for many, many years.
Yeah.
So this is actually one of the advancement of science and medicine whereby you have this life-saving treatment. But of course, we know that dialysis is not perfect, right? Just now I just mentioned two functions of dialysis, but we know that the kidney have a lot of more function. So there are certain functions that the dialysis cannot actually cover. Yeah, so that's why people who are on long-term dialysis, after some time, they do suffer from long-term complication. And a lot of these are related to the heart. So many people suffer from heart failure or even heart attack after long-term dialysis. Of course, this is not due to the dialysis. It's just due to the fact that dialysis is imperfect. It cannot actually cover the function of the kidney completely. Yeah. So of course, it's unfortunate that the statistics show that the 5 years survival of dialysis patient is actually less than 50%.
I see.
Yeah.
Okay.
And that's the reason why we want to talk about transplantation. Yeah.
But dialysis, when you say long-term dialysis, is it for life? Once a patient has to go on the dialysis process, it's for life though.
If you are talking about you starting dialysis because this particular person already entered end-stage kidney disease, then the dialysis is about long-term dialysis, which is lifelong, unless you have a chance to do transplant.
I see. So it's life-saving. Dialysis is a life-saving process, but we have to bear in mind as well that, a patient is bound to this for the rest of their life. So, that's why it can be hard on them. You need to go on a weekly basis. You need someone to bring you there. You have to be disciplined. You have to take care of your foods and, food intake and all sorts.
Correct.
It's not just going to dialysis.
Yeah, and more importantly, it's about the survivor. Yeah, just now what you mentioned probably related to the quality of life, to the socio-economic impact, but the important fact is also about survival. So we talk about dialysis patients have much shorter survival, but transplant is the only treatment now that can actually reverse this.
unfortunately, not every patient will have the privilege of being able to have a kidney transplant. So when we go, let's go into the operating room, the operating theater. So Prof. Shankar, you touched a bit about the procedure that's involved. There's also a lot of myths when it comes to going into the operating theater, because that's where people are mostly afraid of. Like what we mentioned before,
Absolutely.
that's where the fear stems from, right? Going into the operating theater, you're cutting them open, and they don't know what happens after that, right? So there's a lot of stories maybe or misconceptions that people think, okay, once the doctor or the surgeon takes out the one of the kidneys, they will replace it with a spare part and treat the body like a car or something. Or maybe, it's going to be sold on the black market. All the other organs are going to be taken out and removed from the body. So people are also afraid of that, besides the invasive part of the process. Have you heard of these fears? Or
Absolutely interesting that you have
Yeah.
brought this up. I have been asked this question by the patients actually when we counsel them
Okay.
for surgery. So if we were go into a bit deeper into the surgical aspect of kidney transplant, as we mentioned earlier, there are two parts to this. One is the donor operation. A separate team does the donor operation.
Yeah.
And we do it minimally invasive. That means laparoscopically, i.e. keyhole surgery. Okay, so the kidney is retrieved and then it is preserved to be implanted onto the recipient. So in the recipient, your myth is absolutely right. This is a very important question that we need to address with our recipients, because they always think that, okay, the kidney has failed, like how our car parts fail sometimes. You just have to remove it and just, ganti balik lah, just change it,
So, but what happens in an actual surgery?
In actual situation, we implant it onto another place called the pelvis. Near the pelvis is the lower abdomen. Okay, towards the right or towards the left, but it's on the lower abdomen. The reason being, the vessels are short. The tube that brings the urine down to the bladder is also going to be short, and we cannot. The removal of the organ from the recipient is another 2 or 3 hours surgery. So we can't implant it onto the place where the native kidney is situated.
Ah, okay.
So it has to be implanted onto the pelvis.
I see.
Very close to the lower abdomen, if you want to look it on a layman point of view.
So the layout of the organs will also differ. We'll have to change a bit for the recipient
Correct.
patient.
Yes. So we need to implant it, and then we need to make the connections where the blood vessels that bring oxygenated blood and non-oxygenated blood, which is the artery and the vein.
Okay.
So you need to make those connections with the native blood vessels of the patient.
Yeah.
And also we need to connect the tube that brings the urine down to the bladder onto the bladder. So that is the gist of the operation actually.
Okay, so after the operation, let's go into more detail about the post-transplant life. We've gone through that a little bit before, but what are the lifestyle changes or the medication that's needed, the follow-ups that's needed? We did say that, they need patients or donor patients, they need to come back for follow-ups and such. But what kind of lifestyle changes will they need to do once they have gone through the transplant process?
Of course, we always tell patients saying that after transplant, they will go back to normal, right? But
it's not true.
that probably oversimplify the process, right? So generally, the recipient will stay in the ward for about 7 days. And this is definitely an advancement in terms of medicine and science as well, whereby the donors stay for only 2-3 days and recipients stay about 7 days. And this is actually pretty short duration. Then after discharge from the hospital, the recipient is essentially have to come back to hospital very often. So based on most of the hospital protocol, the initial 3 months is a very intensive period. That the first month, we make them come to hospital 3 times a week. Then the second month is 2 times a week. The third month is once a week.
This is just for the first 3 months post-op.
Post-op.
We don't want to scare all of you. I mean,
yes.
when we say that your life is not going to go back to normal, it's not as if they will completely change. I mean, their body functions will completely change. That's not true as well, right,
No,
Prof?
the reason why we want them to ask to come back is just for close monitoring.
Right.
But essentially, they are functioning normally. At least they do not need dialysis.
Yes.
Right? Previously, they probably attend 3 sessions of dialysis a week. Now, they do not need to, even though they still come to hospital, but come to hospital mainly for blood checking to make sure their kidney function is all right.
So this is for the patients who have received
Recipient.
a new kidney from
Yeah.
the donor. So that is what they will have to go through.
Correct. So the initial 3 months is probably a bit intensive for them. But after 3 months, if their functions are stable, so essentially we'll space out the follow-up. Yeah. But the important thing is also, of course, the diet will change. Right? Because during dialysis, a lot of diet restriction. A lot of things they cannot take, high potassium, high phosphate, all this thing. But when they actually, after transplant, if their kidney function is normal, essentially they just take like you and me.
Yeah.
With some restriction. Means I always tell them, you have to forget about your sashimi. Raw food, no to them because they are immunocompromised, right? So you suppress them with the immune.
We can do without Japanese food, right?
There are many other options.
That's one thing that we know. I think human beings are really resilient individuals, resilient human beings. So we can adapt to change, especially if it means living healthier, if it means taking care of our bodies. I'm sure we can make those adjustments in life.
Yeah, you are right. Most of our patients take that very positively. Even though some of them might like sashimi before, right? So that's just about raw food. That means everything they eat have to be a cook.
Yeah.
It's just
in Malaysia, there's no problem with that.
Yeah, it's just to reduce the risk of infection.
Right.
Yeah. So then
Patients should be motivated to come to hospital, because imagine you're coming to hospital to do dialysis 3 times a week.
Yeah.
How stressful that is.
Yes.
And compare it with post-transplant, you come to hospital to get your blood checked, get the good news of your kidney working fine.
Which one, looks brighter. Because dialysis is a lifelong commitment.
Correct. It's a major lifestyle change there, to be on dialysis 3 times a week. But coming to hospital to do a checkup for post-kidney transplant and get good news.
And that is temporary, right? 3 months.
And you're passing urine again. Imagine, when you're on dialysis, you hardly pass urine.
And if you're going to a hospital like UMSC, where it's, it's a really nice hospital with good hospitality and all that. So, what is a trip to the hospital? But that is that's the future of a recipient. Patient, right?
Yeah, another thing before we move to donor.
That's the most important thing he's going to say now.
It's about, of course, medication, right?
Yes.
Right.
Because our body is a very clever system, right? So if you receive a kidney from somebody else, you can always recognize that this does not belong to you. And so our body immune system will tend to reject it, right? So we have to use these drugs called anti-rejection treatment to actually
drugs
prevent.
also called anti-rejection,
Anti-rejection, yes. Of course, in medical term, we call it immunosuppressant because it suppresses the immune system. But in a simple term, the work it does is actually anti-rejection. So prevent our body from rejecting the new kidney. Yeah? And this particular medication is lifelong. It's lifelong. And this is something very important we emphasize to our patient because we do have occasion where certain patients, they take it for granted. After 10 years, they thought they have recovered. Then they stop the medication themselves. And that ended up with rejection. The rejection happens. So even after 10 years. Yeah. So that's why we always emphasize to our patient, don't take it for granted unless your doctor tell you can actually drop one of the medicine, stop because of some reason, you can stop it, then that can be done, but you cannot stop it yourself. That has to be taken regularly. And
is it on a daily basis?
Daily basis.
One type of medication though?
Usually it's in a combination of 3.
I see.
Yeah, but if you, in terms of comparing to the number of medication you need to take during dialysis, it's much, much less.
Yeah.
Yeah, because in dialysis, they probably take probably up to 8 or 10 types of medication. Yeah, now it's reduced to 3, which is, to me, is an improvement.
Definitely.
So,
yeah. So now let's go to the donor side. The donor's side. What is the future looking like for them once they have donated one of their kidneys?
Yeah, of course, the wound healing part, I will leave it to Shankar. I'll just mention a few things that a lot of donors might have a misconception. The first thing is they do not need medication at all after the donation.
That's a misconception.
Yeah, because a lot of donor might ask, do I need to take medicine after the surgery? And I think they do not need that. Yeah. And the second thing is, as a non-surgeon, I view that now donor surgery is much minor compared to previous.
Yeah.
Last time I used to show in the lecture photo of our donor where they have a long scar because our kidney is at the back.
Yeah.
So last time if you do open surgery, you have the long scar. And now you just have a 3-hole, right? Because it's a keyhole surgery. So that is, to me is a
Less invasive, right?
yeah, it's an advancement. And the hospital stay is so short. If you compare to what kind of surgery you have 3 days of hospital stay, probably gallbladder operation.
I mean, even when
something like
giving
that.
birth, you stay for 2 or 3 days. only.
So that to me as a non-surgeon, I view that is already an advancement and people actually do benefit from that. So, and many of them, they can go back to work pretty fast because it's actually a very small wound.
Yep.
As long as the wound heal. Of course, we advise them on some simple measure, for example, no heavy lifting. And of course, more importantly, we remind them, please come back to see us. Of course, the initial 1 year, we'll see them more often, probably 3 months. Every 3 months we see them because the kidney will take about 3 months to undergo that kind of a compensatory mechanism that we mentioned just now. That means the remaining kidney will compensate, will get bigger to take over more function. And that process will complete in 3 months' time.
Okay.
That means at 3 months, you will be able to know how is the remaining function of the kidney after your donation. Yeah, then we will continue to follow up. So after 1 year, essentially, it's just yearly follow-up.
Okay. So firstly, no medication is needed. And number 2, follow-up care is needed. And number 3, not many major lifestyle changes that is needed on the donor's part. So this is life for the donor after a transplant occurs. Prof. Shanger, do you want to?
I just want to add on the wound thing. What is the most painful part of the surgery is the wound actually. You can do any heroic procedure within the abdominal cavity, but the most important, most painful part of the surgery after during the recovery period is the wound. So now with technological advances where we can do it less invasive, like you said, with keyhole surgery. So the pain relief is requirement for pain relief is very minimal.
That's good news.
Yeah,
That's good news.
And the operation has become much simpler to do. And like what Prof. Lim said, they can just go back within 3 days and get back to work within 2 weeks and carry on with their normal life until this compensatory mechanism takes place and the risk is minimal actually for future kidney failure.
At UMSC, how important is it for evidence-based approaches to be used or implemented in shaping treatment plans at the hospital? What does it look like in day-to-day practice?
Of course, in our medical practice now, everything have to be evidence-based. Right? It's not just transplant. So of course in transplant...
What's the difference actually, firstly, between evidence-based and transplant?
Transplant is a part of the medical practice, right?
Okay.
Yeah, so whatever we do in medical condition, it has to be evidence-based. That means you have to actually have some basis why you do like that. Right? You cannot simply say, oh, today I feel that I want to do this, I just do, then tomorrow I do the other way. Right, so that is not like that. So everything have to be evidence-based, learning from whatever study that have been done before, whatever reports that people have produced before, right?
Okay.
But transplant is actually a program that we can actually protocolize a lot of things. That means you can actually write into a protocol and say, okay, for a standard transplant, what you want to do, what kind of medicine you want to give, what dose you want to give, and all these things. That can be put into the protocol.
And that's not evidence-based approach?
That is evidence-based.
Oh, that is?
Protocol is based on evidence. That means what kind of drugs has been proven to be effective and all this thing. That can be put into a protocol.
Okay.
But the challenging part is not about the protocol because protocol is very standard. That means everyone, you just do the same thing. I think the challenge will be how experienced is the team to handle complication. Because sometimes you might plan like that because transplant is an elective operation, right? You don't do under emergency. It's a well planned, but sometimes things might go wrong, may not actually follow what you think. So the challenge will come when how experienced is a team to handle complication. And that will decide the outcome of the transplant.
I see.
Yeah. So because surgery, anyone can do, right? So because it's fairly standard, the immunosuppressant is also fairly standard. If you go to US, we are also using the same drugs as here. It's fairly standard. So the challenge is actually the experience of the transplant team in terms of handling the unexpected thing that might happen in the process.
So that's your team, right, Prof. Shankar, as well.
No, for us, if you want to look at evidence, probably, our work is mainly technical. So it is a procedure that we need to carry out based on our learnings and our training, isn't it? So I think maybe evidence comes in when we want to select the kidney. In case due to technical reasons, we may want to choose the better functioning kidney, then we will be supported by our nephrology colleagues who will make all this, they're very smart people, the nephrologists.
Of course.
They will make all these
Both of you.
calculations. They will make calculations based on evidence, and then they will advise us, okay, it is safe to actually procure the better functioning kidney, for example. So that can be evidence-based. And of course, all the complications that are possible in this kind of surgery need to be evidence-based in order for us to counsel our patient.
That's right.
That is very important. From rare complications to common complications. So that helps us counseling before embarking on the surgery itself.
Okay, we cannot deny that technology, as we've mentioned, has helped us advance in the medical or health sector. It transforms kidney and urological care at UMSC in particular. What are some of the tools or systems that you see, that you're excited about, that are set to become part of Malaysia's healthcare standards, that are becoming more common in the use of in healthcare, in the healthcare landscape in general?
Before I answer that, I probably will tell you some of the our challenges, in terms of managing the patient post-transplant, especially. So, as I mentioned just now, we use anti-rejection therapy, right? So, when we use anti-rejection therapy, one of the important thing is how to strike a balance between suppressing the immune system low enough to prevent a rejection, at the same time avoiding over-suppression. Because when you over-suppress, patient will suffer from infection, they might get cancer and all these things. So balancing is actually a lot of time we say this is an art rather than science, because it's not easy to actually say, okay, how much to give in the long term, whether it's time to cut down or not. Because sometimes if you cut down unnecessarily, then patient got rejection. Right? Yeah. So nowadays, I think with more technology and also kind of biomarkers and all these things, we do see it can help us to be more personalized. Yeah, just now we talk about standard of care. So everyone gets standard of care, everything the same. If you are a standard patient, we give you a standard of care. Everything can be put in the protocol. But the next thing we want to aim for is how to be personalized, because we cannot say all the patients are the same, right? It's not the same.
That's why I think we use AI now.
Yeah.
AI can provide more personalized care for our patients. It's more patient-friendly. It really caters to their needs and supports what they need.
Yeah.
Would you agree, Prof. Shankar, as well? I think you use technology a lot.
Yeah,
when
AI can be a tool to enhance patient knowledge as well as decision-making process. But if you look at technology from our side, the laparoscopic procedure is a technological advancement where we can perform this operation quicker with less invasive nature and better recovery. But what is in the horizon is probably robotics. Robotics is in the horizon. Where
replace what you do? Robots replace surgeons?
That's a myth. That's a myth.
I know the name is called robotics, not robot doing the surgery.
This robot is not too intelligent.
No one will be able to replace Prof. Shankar.
So we need to control these robots.
Yes,
But the robotics may have a role in transplant surgery, especially in the implantation process for a recipient, because sometimes we have technically challenging operations in an obese patient, for example. Obese patient or a very deep pelvic cavity where we need to implant in a very difficult area of the body, So the robotics might be helpful. So we are all learning robotics now. It has come into our hospital setup as well. So once we get better and better in handling these robotic procedures in other surgeries in urology, then we can slowly move to probably trying recipient surgery using robots. So that is a major advancement that will be helpful for surgeons.
With all of these technological advancements, it translates into comfort and ease and convenience, I think, for the patients. So I think that's something that we should bear in mind as well, that technology, sorry, I gotta do that again.
Yeah, probably I would just add a little bit on, probably choose 2 examples to illustrate how the technology will assist us in terms of managing patient post-transplant. So just now I mentioned about balancing between under suppression and over suppression of the immune system. So now we do have a test which can actually allow us to actually know whether this particular patient is under suppressed or over suppressed. Right, so this is it's actually a virus. It's a virus, but this is actually the virus does not cause harm to the body. But when we measure the virus count, if the virus count is high, they say, oh, the immune system is too weak because the virus is coming up. So that is a time when we want to actually reduce our medicine. So if the count of the virus is actually low, then they say, oh, you are basically not over suppressed. So that is actually something coming up in the near future. And for the meantime, Malaysia, we are doing a multi-center national study to actually get more insights into this particular virus. It's called tenovirus. It's a very, the short form is called TTV. So it's a very, very interesting idea that people are saying that you act like an immunometer. It tells you about your immune system, whether it's high or low. So that's actually one of the things we are very excited that we are going to embark on a multi-center study involving the MOH hospital as well. And the other thing will be about, you're talking about rejection, right? So I did mention just now saying that traditionally, how do we diagnose rejection is to do a biopsy. That means you put it in a needle, take a bit of tissue from the new kidney, send to the lab. The pathologist will look under the microscope and say, oh, there are cells infiltrating into the kidney. So the body is actually rejecting the kidney. So that is our conventional way. So even though we always counsel patients, this biopsy is a minor procedure, but we do have patients who actually have bleeding problem. So it's actually, so now we actually have non-invasive method. By just taking a blood, you can already tell whether this patient is having rejection or not. So you can see we are moving toward more personalized kind of way of managing our patient, that we are cutting down a lot of unnecessary risk. We do not need to do biopsy so often now. Of course, currently, our issue is about cost. Because all these tests, for example, the test which is called cell-free DNA, we have to send overseas because we do not have a local lab performing this kind of test. But with the access, if a patient able to bear the cost, we are able to cut down all this procedure. And I see this positively, that in the future, we might be able to do it locally, that we can actually give access to more patients and they can benefit from all this advancement of technology. Yeah.
Okay, wow. Thank you to Prof. Lim and Prof. Shanga. A lot that we have unpacked we have discussed about diagnosis to dialysis to surgery, and the common goal or the common theme that keeps popping up is teamwork. Is a teamwork among doctors, specialists, the experts, medical physicians, also the patients, their families as well. I think they all play a part and work as a team together with you. And so to all of you watching, whether you're thinking about organ donation or just want to protect your kidneys or want to, of course, take care of your health, the first step is knowledge. So hopefully today's conversation has given 1 or 2 nuggets of very useful information on your health, on your kidneys. And of course, the next thing to remember is to take action for ourselves and for our loved ones around us. So if this episode has helped you, please share it. QRate us by subscribing, following, sharing, commenting. And till the next episode, please everyone take care of your health and stay safe. Bye everyone.
Did you enjoy today's curated episode? Well, don't forget to tune in for the next episode of Curated Podcast by UMSC. To learn more about our consultants, specialties, or to book an appointment, visit umsc.my. For health tips, behind the scenes content, and expert insights, follow UMSC on Instagram, Facebook, TikTok, Spotify, and Apple Podcasts. Till next time.